Welcome. Welcome, everyone. It is indeed a pleasure to welcome this talented faculty from the American Academy of Pediatrics and many other academic institutions who have joined us today for the 2026 ECOSOC Partnership Forum virtual side event. If you have any questions for the speakers during the presentation, please write it in the chat box or at the end of the session, contact them directly. Their contact information is written in the speakers list. So let's get started. Okay. All right. I think everybody can see that. Title of today's side event is Our Collective Advocacy and Global Platform for Education and Health Sectors. The aim of this side event is to understand the potential of social and economic impacts that quality education and improved healthcare can bring in achieving peaceful coexistence. For the initiatives of Women's Health and Education Center, its acronym is WHEC, have been hard at work for the last 2 decades to achieve education and health for all. It is at the heart of our projects and program to focus on eliminating poverty, hunger, and achieving the United Nations 2030 agenda. This is our agenda today. Our background: Women's Health and Education Center, WHEC, was established in 2001 to undertake the projects and programs with the UN, WHO, and UNESCO to improve education and health needs in collaboration with both developed and developing countries. WHEC's chair program for research and educational organizations and networks was launched in 2022 in collaboration with UNESCO and Higher Education Sustainability Initiative, HESI. Action Group is Sustainable Development Goals SDGs Publishers Compact to improve sustainability of higher education and literacy for all, with special focus on women, girls, minorities, and migrants. It is fostering collaborative research partnerships and networks in both developed and developing countries. This idea of internet classrooms in education and health sectors was launched in collaboration with the Department of Public Information, DPI, at the United Nations on 24th October 2002. Today, our continuing education and continuing medical education initiatives are accessible and serving in 227 countries and territories, about 14 million subscribers per year. Never underestimate the power of communication and planning and developing projects and programs of mutual benefit and mutual respect. Least developed countries lack resources and they are burdened by mountains of debt, but we cannot leave anyone behind and we cannot let them down. Our collective advocacy, future of education and health is digital, and this is core enabler of UN 2030 agenda. A coordinated action across sectors is needed for the greatest impact. Our initiatives have a unique role to play in strengthening the health and educational systems worldwide. Cultural diversity is now the norm in each and every country, and we all provide services to multicultural societies and communities. The global movement towards the education and health for all will facilitate the United Nations 2030 agenda. Our future is not predetermined. We have choices among conflicts, climate change, and inequality. By harnessing the creativity of 1.45 billion young people, we can pursue financially and rewarding and transformative pathways. Women's Health and Education Center proudly joins forces with the UN and UN system in this multipolar world. We can eliminate poverty, hunger, and inequality by investing in education and health in rich and poor countries alike. Please review the details of these efforts of our lifelong learning page. The link has been provided to you here. Use it at your convenience. Dreaming the future and planning the present. This initiative of WHEC Link Access Project was first presented in 2018 high level political forum and was very well received. LINK is an acronym and it stands for Learning, Innovating, Networking, and for Knowledge. It was launched in 2013 in collaboration with the Human Reproductive Research HRH division of WHO. We are grateful to our writers, editors, and educators for supporting this initiative. Knowledge that touches patient is a vision for globalized world. The use of information science and telecommunication to support the practice of medicine when distance separates and caregiver from the patients, it is the way forward to make medical care more affordable and more accessible in every country. Lessons learned and best practices. Even though each country has its unique culture, economics, and politics, they all share similar developmental challenges. This whole world is a developing country. Some have a longer way to go than others. Women's Health and Education Center respects the rights of patients, colleagues, and the communities. We plan development together. In this forum, we are all equals, working towards a common goal to eliminate poverty, hunger, and to improve quality of life for everyone. Our partners' voices and our community voices. Our initiatives have a unique role to play in strengthening the health and educational systems worldwide. For policymakers and individuals alike, this means planning for future and the working together. For the last 25 years, Women's Health and Education Center, WHEC, is hard at work to achieve quality education and universal health coverage. We thank WHO for their collaboration, CSO, Civil Society Organization Network, for publishing our lifelong learning project on World Map, continuing medical education initiative for the globalized world. These are the links. Please see them, review them at your convenience. And we are grateful to Secretary General Mr. Ban Ki-moon and Mr. Antonio Gutierrez for sending us a very encouraging acknowledgement. And we are also grateful to Higher Education Sustainability, HESI, and UNESCO for their collaboration. Please review the links, and if we could help you with your projects and programs, please feel free to contact me. Now, to summarize, we must foster our societies where everyone is included, expanding UNESCO Chair program and promoting global collaboration, fostering inclusive digital transformation, building the capacity to care, preparing the next generation of healthcare providers in the international arena, deepening their knowledge and improving the skill set of a career in global health and global governance is urgently needed. Special thanks to UN Chronicle This is the link for publishing our article on improving maternal and child health through education. Review this link and this article at your convenience. Thank you very much. And if we could help you with your projects and program, do not hesitate to contact me. Thank you. Okay, now it's indeed my pleasure to hand over the platform to Dr. Colleen Kraft, Professor of Pediatrics at Children's Hospital, Los Angeles, California, and 2018 President of the American Academy of Pediatrics. She is sharing us a very controversial topic in USA for sure, vaccines and autism. Go ahead, Colleen. We can't, Colleen, we can't hear you.
I have to unmute. There we go. Okay. Well, no, that's it. Thank you for the introduction. Part of the problem is that there really is no controversy about this. All of the research tells us that there is no relationship between vaccines and autism, and I'll go through the entire story. But what it has done is it's created a lot of access problems and barriers for many of our families who are confused about who is saying what about vaccines. So, in terms of learning objectives, we want to recognize how misinformation has fueled the myth that autism is caused by vaccines. We want to identify the threats to child health that are given this misinformation about vaccines. And then finally, we want to be able to commit to discussing the truth about the science and protecting children and child health and child rights through immunization. And this is the problem. Ever since this new administration has come in, the person at the center, who is our Health and Human Services Secretary, Robert F. Kennedy Jr., has been an anti-vaxxer and has been fueling vaccine conspiracy theories for decades. But what happened is that there have been many things that have broken down the public health system and the vaccine system, and it is leaving families confused and worried and not knowing quite what to do. And it has set forward a huge measles outbreak. We have the largest number of cases of measles in decades in the United States. We're seeing pertussis, whooping cough come back. We're seeing other diseases come back as well too, which is really very sad and very unnecessary. If you look at autism prevalence rates, this was some of what spurred on the concern here. In the year 2000, there was reportedly 1 in 150 kids who were diagnosed with autism. And that has steadily risen throughout the years to 1 in 31 in 2022. I will go on to show you the reasons for this. The reasons for the increase in autism prevalence rates have been largely the expansion of the symptoms that we are including in autism spectrum, and really the recognition that it is a spectrum, that some kids are much more affected by autism than others, and that we have much better screening, we have much better diagnosis, and we have much better treatments for autism, which has made that higher prevalence rate actually a good thing because we can now identify these problems and treat them earlier. But why the concern? Autism is often diagnosed in early childhood, and the incidence of autism has been rising. Vaccines are often given during the same period. So the timing can create this illusion of causation, and scientific evidence has to be used instead of coincidence. So where did the misinformation start? Well, this all started in 1998 with a study by Andrew Wakefield that claimed a link between the MMR vaccine and autism. And the study was involved in 12 children, essentially looking at the guts from 12 children and finding some antibody to MMR. Later, this whole study was found to contain false data and ethical violations, and so the study was fully retracted by the medical journal, which is the Lancet, and Wakefield lost his medical license. Multiple investigations confirmed fraud, and the paper is no longer considered to be valid science. Sadly, the misinformation has remained. What happened after this was, and the MMR, was that there were other explanations. So when MMR was shown to not cause autism, well, it must be the thimerosal, which is a metabolizable form of mercury in the vaccines, or it must be the aluminum in the vaccines. Well, what happened was thimerosal was removed from childhood vaccines years ago, and autism rates did not decrease after the removal. Aluminum levels in the vaccines, aluminum is used as an adjuvant. It is what makes the vaccine work and develop antibodies. And those levels are far below harmful limits. So the organization where Robert F. Kennedy Jr. worked for much of his career was a group called the Children's Health Defense. And this is a huge anti-vaccine group, and has published materials such as Mythology, Ideology, and Reality. And where vaccine advocates proclaim that they follow the science, they actually ignore the science. And vaccine development has really been a very scientific process, but this is something that has been downplayed by this group and other groups. Further research on vaccines and autism have resulted in dozens of studies involving millions of children. Again, that very first paper had 12 children in it, but the research on the safety of vaccines not causing autism have been done in millions of children across multiple countries, looking at comparing kids who are vaccinated versus kids who are not vaccinated. And there is no difference in the autism rates in the United States, Denmark, the United Kingdom, and Japan. The graphic I have on the right side of this slide comes from the American Academy of Pediatrics. And if you look up the American Academy of Pediatrics and fact checked, it will go through every one of the vaccines and where the research is, and the research that shows the efficacy of the vaccine as well as the safety of the vaccine. So the research is there. This is a great resource for finding it and showing it to other people. Well, why the increase in autism? First of all, there was a change in definition. Before the DSM-5, autism had a number of different flavors to it, including things like pervasive developmental disorder and other things. Autism spectrum disorder was lately defined as a characteristics of having difficulty with social communication interactions and having restrictive repetitive behaviors. And because that spectrum was defined and was very broad, a lot of kids were able to really meet the criteria for autism spectrum disorder, which is important because then they would meet the criteria for what could be treated for them. Secondly, around 2000, there began a big push for developmental screening and better detection of all kinds of developmental delays, including autism. And then finally, there is better recognition, not only from physicians, but primarily from therapists and teachers and the schools. There are better therapies, and then there's strategy for treatment. These are things that are addressed within the school setting in individualized education programs for kids. And because of this, we have more kids who are helping to move through some of the symptoms of autism, and they're better able to be successful in school and in social interactions and have jobs and have good lives. So, how does this interact with some of the storms in childhood vaccination in 2026? Well, what we are seeing is that there is political ideology, leaders who do not believe the science, and leaders who place loyalty over truth and best decisions for children. There is misinformation and disinformation. So, vaccine preventable diseases have been forgotten. The accusations of vaccines causing harm that don't have evidence. And then the wellness influencers who discredit vaccines in favor of selling their products. This is really a big problem that people are all over social media saying you don't need to vaccinate. If you only take my supplement, you will be healthy. And that the social media algorithms are confusing parents and promoting vaccine hesitancy. So a parent might do a search for what is the side effect of this vaccine, and they will be thrown into the algorithms with all kinds of misinformation. And then finally, because of decisions made during 2025 in Doge, global funding has decreased, and we've had decreased financial support for vaccination programs around the world. There have been fundamental leadership changes in the United States. The group called the Advisory Committee on Immunization Practices were all scientists, vaccinologists, doctors who worked in the field of studying vaccines. They were replaced by a group of primarily anti-vaxxers that Robert Kennedy knew. And because of that, there has been a change in the childhood immunization schedule and a real erosion of immunization as a core strategy for prevention. One of the changes that has been made has actually been in the birth dose of hepatitis B vaccine, which we know is 99% preventable, preventing hepatitis B in infants, which goes on to cause chronic problems with liver failure and in some cases liver cancer. That's no longer recommended universally. Now, most of us doctors are actually saying you really do need to get this vaccine. But as a public health strategy, it's not something that's present in our schedule anymore. USAID funding cuts were really tremendously awful. They restricted health services, and so vaccine distribution is slowed. Nutrition programs have shrunk. Preventive care has really become available in many places, and that results in surges in preventable diseases and higher child mortality rates. And then the health challenges that impact a child's ability to learn and grow. Social media and wellness influencers. The misinformation is spread very rapidly through social media, and the factual content is suppressed due to algorithms that favor engaging, alarming content, echo chambers where people only see information that confirms their beliefs. And then the repetition increases the perceived truth that makes falsehoods feel credible over time. And so influencers gain followers and they sell their products for whole nutrition, for immunity boosting. There are only two things that boost your immunity. One is disease, and the other is immunization. And you can die from disease. So what happens is that there are misinformation claims that vaccines cause autism, and the psychological impact for our families is that they fear for their children's safety, and so the result is delayed or refute vaccines. The misinformation is that big pharma is hiding the truth. The psychological impact is distrust in big institutions, and so the result is resistance to public health advice. Misinformation claim that COVID vaccines are experimental, and the psychological impact is uncertainty and confusion, and so people have a wait and see attitude. I have a personal story about the COVID vaccine changes with ACIP. My son is actually in Virginia and works in the health department with the vaccine registry and was just charged $700 at his well visit for a COVID vaccine. This is some of the things that can happen when the public health infrastructure is eroded. So, what's our concern about decreased immunization? Well, lower vaccination rates lead directly to outbreaks, and we have seen this. We've seen this in measles. It's resurged in part of the US after vaccination rates fell below the 95th percentile, and we've had 3 deaths and many thousands of illnesses. Whooping cough or pertussis has had similar increase in areas with lower vaccine uptake, and that we know that children who are not fully vaccinated are many times more likely to get pertussis compared to fully vaccinated children. So some of the good news, some of the ways that we are fighting back, the American Academy of Pediatrics has maintained its own immunization schedule. And actually, many states are forming coalitions to require the use of the AAP schedule. My own state, California, is one of them, and we are very proud to be a state that still says you have to be fully vaccinated to go to public school, and that we can't have any shoddy exemptions for vaccines, and that there have been a whole new group of positive social media messages. So when parents ask about vaccine side effects, these are beginning to come into the algorithm. We've had some global health funding wins through the American Academy of Pediatrics. So we were able to get 32.5 million for the Vulnerable Children account, which is a priority for AAP. We've had 915 million for maternal child health, including 300 million for the Global Access to Vaccines Initiative, or Gavi. And we were able to get Bill Gates to actually double this amount. There has been 4 billion funding for PEPFAR, which is the prevention of HIV transmission from mothers to children, and then 5 billion for international humanitarian assistance. It's a new pot of funding that combines international disaster assistance with migration and refugee assistance accounts. So even in all of this, we've been able to do some things positive for kids. So for my final slide, I always refer back to our Sustainable Development Goals because vaccines have everything to do with good health and well-being, with getting kids to a quality education, for reducing inequalities. So, as a summary, autism is not caused by vaccines. The myth began with a fraudulent study. Extensive research disproves the claim, and that vaccines are safe and effective and life-saving, and a coalition of good people will make them available to all children around the world again. Thank you.
Well, thank you very much, Colleen. It was very impressive. And Colleen will be back with us on the Commission of Population and Development in April. Um, Now, let me introduce Mr. Aditya Maheshwari. He's from London today, and he's a data scientist and explaining to us about machine learning and how artificial intelligence can bridge patients with the health system. Go ahead, Aditya.
Thank you. I'm assuming everyone can see my screen.
Sure.
Okay, great. So again, thanks so much for the introduction. Today, what I will cover is one role that the new wave of AI can play in healthcare, specifically in regions that have inconsistent access to care. So, broadly speaking, healthcare improves when, first, clinicians can truly understand their patients, not just their symptoms, but their history, context, and how they have progressed over time. And second, when patient experiences can be connected, so that what is learned from one case can inform another. The end state that AI enables us to move forward to is actually very concrete. It's a system where a user can express and capture their health history through whatever mode they want. That could be like voice recordings, recording of an on-site visit, tests, documentation. So less sophisticated to extremely sophisticated in that sense. The second would be where patients can control their own data and then, with consent, allow clinicians to use AI as a translation layer to access a full coherent story rather than fragments the patient presents. And third, where evidence from one patient can actually help another, especially when they share similar demographics, environments, or health systems. This is an idea that learning can compound from patient to patient. Now, today, care can often be fragmented, but the learning does not really have to be. The question I want to explore in this intro presentation is, how do we capture and connect patient experiences at scale without overburdening patients or clinicians? So I want to approach that question by telling three simple stories. Let me start with the first story, which is like my own experience. So I grew up in Canada, and in Canada, our medical information is in a way managed by the province that provides us free healthcare. But one summer I was visiting my grandparents in India, and we went to a village near their city to visit a farm. Now my uncle, who's a doctor, also came with us. And then once the local villagers realized a doctor had arrived, they started forming a line near where we were visiting, holding their prescriptions in hand. One by one, they were coming to him and asking, can you confirm this? Can you sign this off? Should I keep taking this medicine? And it became a very informal sort of doctor-patient interaction. Now, their prescriptions that they had in hand are almost like a physical token of continuity in a system that could otherwise forget. The doctor has almost no way in this context of knowing what the patient's history is from that one paper he has or she has in their hand. It's not effective, but it's a fragile way to practice continuity. What's interesting about this is it's not that India as a system has failed on scale. They have a national telemedicine platform, which has supported over 250 million remote consultations in just a few years since it was created. At its peak, it can handle even up to 300,000 consultations in a single day. So it's not that India as a system, for example, suffers from some kind of skill or bottleneck. The challenge is at the last mile, continuity for a patient still fits on a piece of paper in the patient's hand. So this means if the patient moves or sees another doctor or comes back months later, it is kind of on them, often literally their own pocket, to represent their own story in an accurate way. And a prescription is essential, but it mostly captures actions, right? So what is prescribed, maybe for how long has it been prescribed? It doesn't really capture what the symptoms mean in a context, what has changed over time, what has worked partially, and what has failed. And at that level of a single encounter, this might feel like a minor inconvenience, right? If someone has a cold and they took some prescription and months later they have a cold and they come back, it might just feel like a minor convenience. But at the level of a system that has already delivered hundreds of millions of interactions, it can become more of a limitation than just an inconvenience. So a prescription in this case can tell us what was given, not really what was learned from the doctor-patient interaction. And that story for me gives us like a simple goal. Can we help that patient show up next time with more than just like a prescription paper? And can we also help them arrive with stored, shareable, and multimodal records of what actually is happening to them over time? So that kind of brings me to the second story, recording the interaction itself. When we talk about digitizing healthcare, especially before this new wave of AI has hit us, often we default to things like long-form surveys, structured fields, standardized questionnaires. This works fine in controlled settings. For example, you can have trials, registries, formal research. Some patients may have like a digital record already. But it runs into trouble sometimes in niche cases in the real world, especially at scale. There can be a lot of communication barriers, time constraints, literacy challenges, and language differences. And more fundamentally, there's a big difference between the richness of a human story and the rigidity of like a table or spreadsheet where their data is stored. So we try to take a narrative, like for example, since last month, my cough has gotten better, but only when I use an inhaler. And I'm more tired when I climb stairs at work. I stopped taking the second tablet you prescribed because it made me dizzy. And we take this kind of interaction and compress it into a few tick boxes and codes. So to capture everything this way, we would need hundreds of questions to really get all the nuances of the doctor-patient interaction. If you ask too few, you may miss what actually matters. And if you ask too many questions to somebody and they have to fill a very long and complex and specific form, it makes people kind of stop answering, honestly, or just stop answering altogether. The good news is people already go to doctors. These kind of conversations already happen, notes are already written, and images and scans are already taken. Real-world care is naturally multimodal. It's spoken conversation, clinician notes, images, scans, visual and behavioral observations. And this is not just, let's say, what a clinician may want. It's also about what patients want from those interactions as well. Roughly 2/3 of patients want to be actively involved in decisions about their care, not just told what to do. So when we record what was discussed, what options were considered, and what was actually decided, we're not really just storing data. We're kind of giving the patient a preference for some shared decision making as well. So the idea is when we think about medical data that we're capturing from these interactions, historically we would think about this as some kind of operational activity as part of the patient visit. However, we can also reframe this as an administrative data question. This means that when a patient is interacting in their site visit, the data collection element is not a separate activity. That visit itself as a whole becomes the data that we then sit our inferences and treatments on top of. So this can, in theory, generate rich multimodal records. For example, audio of the consultation, structured summaries derived from it, images, vitals, symptoms, and other measurements you already take, and then simple patient records updated over time. So once you accept care as multimodal, the bottleneck obviously shifts. It's no longer about how do we collect more data so we know what patterns exist in a population, to how can we capture everything and then make sense of all this massive amount of information we're generating. And this comes into the third story, which is imagine you're a new doctor, perhaps in a crowded clinic, perhaps at the end of a long telemedicine queue. The patient in front of you has seen multiple providers over several years. They may have moved between districts, changed jobs, lost some records here, lost some prescriptions there. They may remember the bigger moments of their life. For example, sometime they had a surgery, sometime they were hospitalized, but not all of the details that could matter to inform today's decision. We know that continuity of care from the same clinician matters to patients. For example, in some studies, we've seen that 6 in 10 patients said they have a preference for seeing a particular GP. And of those, only around 7 in 10 actually manage to see their preferred GP most of the time. Even when health systems try to redesign around pushing for more continuity, improvements often move the proportion of patients seeing a regular doctor from, say, 25% to something like 40%. So the reality of the world is, especially when you're getting to last mile delivery, you may not be able to put the same GP in front of the same patient every single time. Again, for a long time, AI in healthcare was built for small, narrow, and specialist tasks. For example, you can create or collect a number of very highly specific inputs. For example, retinal images or chest CT scans. You would take these scans to a doctor, get them to label it as diseased or normal, and then a model would be trained to spot patterns. Like, oh, the doctor is calling this cancerous, for example. What are the patterns between the image and that cancerous person? And yeah, can we build something to predict whether they're cancerous or not, for example? But they don't really see the narrative. Like these systems can be accurate, but they live in a very thin slice, and they don't see this long context. What has changed now is not just really model accuracy, it's inference and scope. So modern AI systems can now handle long, complex, multimodal inputs, voice recordings, images, and video-free text notes. And then they can kind of combine all of these to give you a more accurate picture of what has been going on with the patient over time. So that's three different stories. In the first, we can see massive scale. So for example, hundreds of millions of teleconsultations, yet a lot of continuity for patients is on the patient to maintain. In the second, we see that patients want to be involved in decisions and that the richest data is already being generated in ordinary interactions. And the third is that we see patients often cannot see the same doctor consistently, even when they want to. And really where we're going is AI can help bridge that gap, not even by replacing clinicians, but actually by preserving and translating the context between patients and doctors. So now I come back to the solution. The idea is if we can start to store these multimodal interactions using existing digital tools, for example, this can be audio of past consultations, clinicians' notes, images, key measurements, then AI can form a translation layer for the new doctor that's seeing this patient. Instead of asking the patient to retell everything from memory, the clinician can actually use AI to parse through the large amount of data that the patient's already given consent for the doctor to see. And they can ask questions like, show me how their breathing and language have changed over the last year. Summarize what treatments were tried for this problem and how the patient has responded. Highlight what is the difference in this scan compared to the last three. Or, for example, given this patient's age, environment, and comorbidities, how do they resemble other patients we've seen in this health system? This answer does not have to be perfect, and it does not at all replace clinical judgment. What it can possibly do, though, is preserve continuity of understanding in situations where personal continuity is impossible. It can surface patterns that a human skimming dozens of fragmented notes might miss. And it can do this while respecting consent and governance, processing sensitive data within national or institute boundaries. For the patient, it can be powerful. Instead of starting from zero with each new professional, they can arrive with this digital version of themselves. And for the clinician, it can be the difference between reading a pile of disconnected documents and having a colleague who has quietly watched the entire series and can give you a recap of what they actually need. So to do this well, in the near term, if we do this well, a few things will follow. In the near term, individual encounters become safer and more humane. So a patient does not have to retell their entire story every time. A clinician can also spend more time listening and listening deeper. And consent also becomes more meaningful because it's attached to a coherent record of what was said and done to the patient. In the longer term, it actually leads to possibly more ambitious goals, specifically around research. So again, when multimodal patient data is stored responsibly and shared with consent, it's now possible to find deeper patterns across patient that can cut across narrow diagnostic labels. So these are patterns that can be more specific to demographics, local regions, local environments, and no matter how many studies we do in the broad scale, where people live and the environments they're living in, which are usually very, very local, they're hard to replicate in those types of studies. So the idea is we can connect that patient who's in a village waiting with their prescription paper to thousands of other patients like him, not by tracking them more, but by listening better to what they've already shared. So to reach this kind of a future, there's obviously going to be a mix of skills and stakeholders. You have to combine technologists, health systems, policymakers, clinicians, and patients. It's likely to be achieved through grassroots work with doctors and clinics because, again, these solutions that exist, especially in places like India, are very local. And then you want to combine those local on the ground projects with structural training and better matching of technology talent to on the ground situations. I think what's clear is that successful leverage of AI to improve healthcare won't really come from institutions down, and it will definitely not come in the form of more painful data collection or painful digital training for people that are already so busy providing care. I think it'll come from giving these professionals, medical professionals, tools that allow them to listen at scale and make sure that like that listening is captured, preserved, and made reusable. The future of healthcare digitization is not really more structure and again more vigorous data knowledge, but it's probably, I would say, centering more around just using these tools as a translation vehicle. Thanks. That's my presentation.
Well, thank you, Aditya. It was quite an eye-opener. As a clinician, I know we have a faith in our IT department, and I'm sure you help us to improve that. Now, my pleasure to introduce Dr. Manisha Johar, a consultant obstetrician and gynecologist in India. She's discussing today about indiscriminate use of antibiotics in India and its harmful effects financially, physically, medically, in every direction. Go ahead, Manisha. We can't hear you. Your audio is off.
I think you have to unmute.
I'll
Oh,
have to
good.
share the screen.
Yes,
Just a moment.
go ahead.
Thanks for the opportunity. Sorry for the basic trouble. Actually, antibiotic resistance is not a new problem. It is as old as the antibiotics. In 1928, when penicillin was discovered, and in 1940, we had the first report of penicillin resistance, even before we realized the importance of antibiotic, and um, uh, we gave Nobel Prize to Sir Alexander Fleming. Before that, we had resistance. And in 1950s, resistance exploded as newer antibiotics came up. And from 2000 onwards, multi-drug resistance and pan-resistant bacteria were there. So we need to understand that we start losing the antibiotic battle the moment we start using the antibiotic. Sir Fleming had warned about it. He said in his Nobel Prize receiving speech that it is not difficult to make microbes resistant to penicillin in the laboratory by exposing them to concentrations not sufficient to kill them. And the same thing has occasionally happened in the body. The time may come when penicillin can be bought by anyone in the shops. Then there is the danger that the ignorant man may easily underdose himself, and by exposing his microbes to non-lethal quantities of the drug will make them resistant. But we got the warning in 1945, but the action began later. Antibiotics are a finite source and resistance is inevitable. This was realized by WHO quite late in 2015 when it introduced the Global Antimicrobial Resistance and Use Surveillance System GLASS. As per AMR, AMR is growing global threat as per the GLASS. 1 in 6 infections are resistant worldwide, whereas in India, it is very high. It is 1 in 3 infections are resistant. And even the common pathogens are becoming resistant to essential antibiotics. But is this data correct? Because even after spending millions of dollars and spending nearly 6 years, this data may not be correct because this was from the government institutes and the corporate private institutes of India. whereas 80 to 85% of the licensed physicians and 93% of the hospitals and 80% of the outpatient clinics, they were missed because they are operated by the small private sector, not the corporate private sector. So we don't know what actual the data is. So public sector, big public sector has been missed in this surveillance, and probably we are seeing the 1/3 of the picture. Why this is important? Because the battle for antibiotic stewardship in India will be won or lost in the private OPD, because the private practitioner and the family physicians, they decide the course of antibiotic and they decide how antibiotics will move. Lot of self medication is there because OTC antibiotics are available, and if we miss this, we cannot ever, because the resistance which is not seen is the most dangerous. Another important reason of contribution to AMR is poor asepsis. Poor asepsis leads to more hospital-acquired infections, more antibiotics, more multi-drug resistant organisms, more deaths, more cost, more resistance. One patient in ICU will cost lakhs of rupees, which is, I think, sufficient for any stewardship. And the bad news is the hospital-acquired infections globally, 7 to 15% infections are resistant. When we talk of ICUs, 30 to 50% in low or middle income countries are resistant infections, and out of these 50 to 70% are resistant organisms. Even in high income countries, 20 to 30% ICU infections are resistant and 30% are by resistant organisms. But the good news is most of the hospital acquired infections are preventable by asepsis and infection control. This is as per the WHO and CDC report. 30 to 50% can be prevented by just hand hygiene, aseptic insertion of catheters and other devices, OT discipline, cleaning, sterilization, and isolation. There is currently no single comprehensive global surveillance database specifically for asepsis related infections like central line associated bloodstream infections or like surgical site infection analogous to glass for AMR. So if we join everything, we will see the real picture. Resistance is rising, definitely. So responsibility has to rise faster if we have to win the battle. The main structural drivers of antimicrobial resistance in India. In the healthcare factors, self-medication, incomplete antibiotic courses, poor infection prevention and control, unregulated antibiotic use in private sector, environmental drivers like contamination from pharmaceutical manufacturing effluents, hospital sewage, antibiotic residues in water and soil, and the regulatory issues like weak enforcement of Schedule H and Schedule H1 drugs, uneven regulation across various states of India, and lack of integrated One Health coordination. We have, and it is not that we cannot fight. We have a Kerala model, Kerala, a state, small state of India. In 2016, when the global surveillance in glass began, Kerala launched a special Kerala Antimicrobial Resistance Strategic Action Plan. There was strict regulation, no OTC without prescription. This was the Operation Amrit. Pharmacy inspections were there and there were penalties for violations. Hospital antibiotic stewardship was strictly followed. Treatment guidelines, audit of prescriptions, public awareness, as Colleen said, narratives are set and ultimately people follow the narratives. So they went ahead of those narratives and set public awareness for misuse of antibiotics. So it was Antibiotic Literate Kerala campaign, community education, school and panchayat involvement. Then there was a surveillance system which was statewide monitoring of antibiotic use and resistance patterns. And this One Health approach, which integrated human health, veterinary, and environmental sectors, did wonders. The outcomes were measurable. There was 20 to 30% reduction in unnecessary antibiotic use in the pilot districts, significant fall in self-medication and over-the-counter antibiotic sales, improved prescribing behavior in government hospitals, better infection control and rational antibiotic selection, and Kerala recognized as a national model for AMR containment. But somehow the things couldn't spread to the other states. There are financial restraints, but I propose wide insurance coverage to cover outpatient clinics can take care of most of the funds, because it will make a data drug-wise, doctor-wise, city, state, nation-wise, antibiotic usage. And I know then Aditya and other AI things can further streamline this. The overuse and misuse can be identified if we have data. Tracing history of ICU infection, investigations done, and antibiotics used. Because even before the patient lands in ICU of a corporate hospital, I'm talking of private, we see meropenams have already been used. So the things are in such chaotic that ICU people are at times not left with anything to use. So audit of ICU sepsis, what ICU is doing and how patient landed in ICU, the whole history. Then uniform regulation across all states of India. And this is not difficult, because India's fight against COVID-19 is appreciated by everyone. We created public awareness at a big level. Investigations were reported. Each and every investigation was reported, and drug delivery was by proper hands. It was not OTC, and follow-ups were very, very meticulous. And India fought COVID very nicely because of all these things. So let's prescribe responsibility, not just antibiotics. And thanks, everyone.
Thank you. It was indeed a pleasure to hear from a friend from India. Okay, now is our Lucky Gill. She's joining us from Canada, British Columbia. We are fortunate to have her as our NGO representative at the United Nations, and her work and advocacy in ending child marriages and improving literacy of girls, women in India is a legendary work in Punjab and in Haryana. Here she is sharing with us her experiences and her project in India. Go ahead, Lucky. Lucky, hello? She is signed up. I think we missed it. Lucky, where are you? Can you hear?
Sorry, there was too
Oh,
many windows open at that time.
Okay. Good. Go ahead.
Let me share my screen.
Good.
I'm just going to expand it. Okay, good morning, everybody. Can you guys all hear me?
Yeah, we can see you.
Okay, perfect. I'm just going to, first of all, say thank you to everybody. Thank you, Dr. Rita, for always guiding us in women's health and education. I'm very passionate about this particular subject, and coming from India, and now on my recent visit, really witnessing and also being, I was humbled by, all the work that was around me, but at the same time, the awareness was there, which was only under your guidance that I have been year after year, months after months, your continuous work that you put in kept me going. And I saw the need for both of our organizations to, go do the work, and that's exactly what we did. So My main work, as Dr. Rita mentioned, I'm from Vancouver. I'm a founder of Global Grow Power, but I work very closely with Dr. Rita as well, with the Women's Health and Education Center and a representative at UN. And my focus is women's health, hygiene, and also in disaster, crisis, and war zones. And we all know, and I don't want to bore you with a lot of slides. It's basically our focus has been education, education, and education. And as a goalkeeper, it's our responsibility to work on the goals. And we all pick some. And for me, it's the health, education, and equality because they all tie in together. Healthy family system is what gives us the healthy community, and so on and so forth. Uh, Coming to floods, wars, and displacement, with a lot of my colleagues have talked about the social media and how news is right in front of us every single day. We are seeing what's happening. There's fear that's out there. It looks like everything's accessible, yet everything is so far away. And when a disaster hits, it strikes, survival is never equal. Women's health becomes invisible first. And there's many reasons to that. And hygiene, dignity, safety, they're always treated as secondary. Sometimes there is no choice. That is the only way to do it, because obviously survival comes first. But for women, the how we always are, we always do put ourselves second, and we want to make sure there's food on the table and the clothes are dry. Like I was in the flood crisis, so moms were not even looking after themselves to a point where they were so numb of the pain till I talk to them. Do you have these symptoms? And they're like, oh my God, sister, we're begging you. Can do you have anything for us? So yes, like they were so numb. And disasters don't treat everyone equally. And disasters are always disasters. It could be a war, flood, earthquake, right? And outcomes are different. Gender determines the risk, access, and survival. Women carry an invisible burden before, during, and after crisis. And this is not accidental, it's systemic. And also, uh, the way I'm going to talk about, I'm not an AI person. The people I'm talking and representing are the people that don't have access to the laptop or computer, or the ones that do, moms don't. That one generation or the two generations before me, they don't. They're not going to go on TikTok and find, oh, I can do this, or they're not going to go into a classroom session or a village is going to have a computer. They're not going to go there. They wanted me to tell in their ear, this is what you do. Okay, this is what's happening to me, because there's a lot of shame and stigma, and there is huge shame into talking about women's health, especially in India. And I was in North India and Punjab, and a lot of my colleagues, two of my colleagues are from India, and we all know how badly the floods hit our country. And what is happening, what happens during crisis, we all are aware of it. I'm just going to touch a few points. Is basically when the disaster strikes, women lose more than homes. They lose privacy, hygiene, and bodily safety. No access to clean water, toilets, or paper. Menstrual hygiene products. I'm going to say something a little different. What I noticed, there was loads of hygiene products. That one part, I was very proud that India wasn't, especially in Punjab. What I noticed, hygiene products were readily available. Internet played a huge role. Women's groups were sending hygiene products, and men had no problem giving them, but they would just throw them in one house, and then ladies will take them into their houses. But having giving somebody a pad is not, that does not just solve the issue. But still, kudos to everybody that did put that work in, and it was much needed. It is unable to bathe or change clothes regularly. Shelters, or there's no privacy. So basically, loss of dignity is an invisible suffering, and we all know it's a preventable thing. And neglect is what happens. So Health consequences, there are many. UTIs are big ones. And what I noticed was this was one missing piece in that. Pads were there, other aid camps were there, there was medication, but women obviously were not going to these camps. And nobody really talked about UTI. It didn't even hit their mind that, oh, this is something that could be needed. And then other infections in reproductive tract, skin and fungal infection, those are things that you can see visibly, and everybody was noticing those. So that we were sending a lot of those fungal creams and stuff. And then there's long-term gynecological issues and mental health issues. And it is a hidden emergency. Aid kits prioritize food and blankets, not dignity. I will say it's a systemic neglect, delayed care, and health becomes disability here. And oh, another thing that I did notice that there was a lack of female health workers. When I was there, I had my biggest challenge was not enough women on the ground. That I was like, women needed the help. Men wanted to give the help, but they didn't know how to. So there was this barrier that we had. So UTI in crisis settings. Why I chose UTI? I lost a sister, 42-year-old. She was a very legendary focus camera puller, and she worked in born and raised in England. She was working on a film in Ireland, and in about 4 or 5 days, she died with sepsis, and she had UTI, got ignored, and obviously long work hours. And I just really, when I went to India this time, I'm not showing any pictures here. I will kind of show you all the pictures at the end. So basically, a little story that I'm going to share is. While I was in India, I really assessed the situation. What is happening? Originally, it was just the uh, okay, I'm gonna go one village to the other. So I spent one full day. I went to 5 different sites where the aid was being given, and I asked, "Where are the women? Can I please speak to the women?" Sorry, I'm just going to um,
Hello?
bring. Yeah, can you guys
Hello?
still see me? Hello,
No, go ahead.
can you guys see me?
Yes.
Okay, so from one to the other to the other. So what was happening in Punjab? The aid was way too much. It was like there was too much food. There was everything was there, and I saw the camps and the medications. I saw it was they were basically the painkillers and some creams. Something for fever. Again, one of my colleagues shared people will line up and they were just taking that medication and when I went there, I asked, I need to talk to women. There's no women in the village. I was like, no, there are. I need to speak to the women. And they wouldn't let me talk to them because they were done. They didn't want one more person. It's like, one, they didn't take me serious, and which they were wrong and apologized towards the end. And I was very persistent. I needed to see them, and I said, they're like, no, there's enough medication. We don't need it. There's a camp in here. We go every day and give medication. I'm like, what are they going to do with so much paracetamol and dolo every single day? This is not like a meal that you're giving them. I need to speak to them specifically about a women's issue. Can I speak to the women? Went from one to the second, third, fourth, fifth village. One guy told me, he's like, sister, you can just leave all the stuff here. We'll send it. I'm like, no, I need to speak to the women. So what I started doing, so one side was um, the flood water, and then there was the one big barrier that men had made, and the other side was a bit dry area. And one major thing happened. It was the end of the day, and me and another young girl, we needed to go to the bathroom. So there was a house in the farm, and we ran to their house. They had a grandma who had a heart attack just when the flood had hit about 15 days prior, and she was on the bed with a bag on her, and her bag was red. And I was like, oh my God, when did you guys last changed it, right? And they're like, oh, when she she was treated. So basically nobody knew, like, this, like, she couldn't speak anymore because she got paralyzed. Was 80 plus years old. So she had basically a really bad infection inside. And that's where I was like, no, the work needs to be done. And one grandpa came to me, asked me, um, what kind of symptoms are there? And when I told him, like, burning or this kind of pain, and he came in, told me in my ear, he's like, my granddaughter um, is in a lot of pain. And next day we took the girl needed to be hospitalized, and she basically had a UTI. And that it kind of started from there. And then while we were ending our day at the last village, I just decided to go through the water. It was like, I think that day the water was above our waist, and I saw some women sitting on top of the roof of one house. And I basically simply just asked them, I said, hey, do you need something? Are you guys okay? And as soon as I talked about, I'm here, I'm talking, do you have any burning issues? Do you have any pain? Do you have any of this? I mentioned some of them, and out of 7 women, 6 of them had infection. And when I asked them, is there more women in the village? They're like, one is next door. And then, yes, there's more women in the village. So I went to the house next door. Something very uh, I think that's something that shifted everything about that trip or that day was when I went to the house next door, and I knocked on it, and the girl just yelled at me. She said, "Don't come inside." And I mean, maybe she could say it too because I was a woman and she didn't have a choice because their house was the second house in that village right after this, the flood water. And so she was done by people filming them. And I said, hey, I don't have a camera. I just had this bottle and some medication, and another young girl with me, sat with her, and she cried so much. And when I asked her, I said, do you have any of these symptoms? Do you need, how are you? And she just broke down and she said, nobody's asked us that part. How am I? And so basically, her main goal was making sure some clothes were dry, there's some food, and she's consistently like all their stuff was on the roof. And I said, if do you think you need this? She said, please give me whatever you have. I just need some medication. They were farmers. They are not the people, like, she doesn't know how to ask for something. They're the givers, they're the farmers. And so there was shame into asking for help for her. And then I'm like, if this has been helpful to you, do you think you can talk to your husband and he can take me to the village and we can speak to other women? And she said, absolutely. So that is when she took me to her husband took us to the village, and that's where we spoke to 35 women, and out of which I would say it was 33 or 34 of them had infection. And those women were so brave. They came onto the camera, and that is the day we just openly spoke. And the video went viral, and it had like 900,000 views in one day. And what I promised in that village that day is that we're going to come back in 2 days. We will bring doctors, and let's do some we're going to do a camp, but we will do it in the Gurdwara. So Gurdwara is the Sikh temple. Every village has one. And guess what? In 2 days later, we had a very successful camp in one village. Everybody was very respectful in the village. Men made sure that, women got out of the houses and got the help. And that is how my work started during the flood. And one major message that I gave to all the organizations that were working that um, I don't need any money. All I need, give me a gynecologist, give me a female doctor, and no money to be sent to my accounts. Just need you guys to support me. I kid you not, I had every single organization backing me that you let us know what you need. I was being given, if I I'm not joking if I say somebody was telling me in dollars, I'll say 20,000, 50,000, and I didn't take a single dollar. And to me, that is the day I realized that it's not the money, it was the power into the education and the voice and delivering it the way those people needed it. And I know that when I went to that village, I actually went and I made sure my clothes were what they needed. But that in no way, you know how there's like um, another thing, maybe is setting in me now that I'm getting older, maybe activist in me 15 year ago had way more like, no, you have to listen. And this time there was something different, even in my tonality when I was talking to them, and I knew I had to be at their level to gain their trust. Women talk to me because they could relate. They could relate to me, they could relate to my story, and they felt safe. And I think making them safe, making them seen, and making them heard was way more important than, just going printing flyers or giving this, giving that. I just kind of, it was like in the moment, I was just acting in that moment. And that is what we did. And it was so successful. So sometimes things don't have to be so complicated. You don't need major funding. You don't need anything. Sometimes all you need is just that one person, that one voice to speak. And uh, in throughout this, another thing that we had done was that in each village, I got young girls who are now our advocates, and then in the future, because the water will come there again, and something will happen tomorrow, but some of those villages will be a little bit more educated. And sorry, I started the story there, because I do want to finish this our slide as well. And also, this was just an example of India. We have seen a global pattern when we have wars, displacement, same outcomes. Women are labeled non-urgent. And example, we can see Gaza, one toilet for 480 people. This is just one. I know the numbers are much higher. And women have used torn clothes and scraps, which we know. And this is something that I used in my one of my videos, that, hey, women are very smart. I know you're giving them pads. They know what to do. The pad stuff they will figure out is the UTI, it's the other things that they need, the dignity, provide them the safe space. I saw one of the video in Gaza. One mom had four daughters. They only had few torn cloths, and that mom would wash them, dry them, make sure her next daughter had them for her periods. Sudan, we have seen 80% displacement in women who can't access clean water. Ukraine, the same thing. Yemen, and then DRC. We've seen this pattern, and Afghanistan, a recent example. I think most of you know about it. Earthquake response was very limited by no-touch policies. Male aid workers were unable to assist women directly. Women were left unattended in shelters and rubble. And some of them also, due to this policy, chose not to take help either, because, a cultural thing. And then that is where the gap in education is. And I think that needs to be done. And aid existed, but access did not. This was a very, very sad reality of our of this day and age. So basically, again, I mentioned it already, but women prioritize children and elders over themselves. Uh, Basically, nobody really asked women, "How are you?" They endured silently, and I believe this is always a crisis within a crisis. There's a lot of mental load, emotional toll, and constant caregiving under extreme stress. No space for rest or recovery. There's fear, anxiety, and trauma that gets unaddressed. So it's not just floods came and went in 1 month, and this issue still needs to be worked on. And I would say women's mental health is inseparable from the physical health. And now, if I'm gonna go here, so I've already mentioned a lot of this, but I as the founder of Global Grow Power, education and empowerment of women and girls is my top priority. And then my work with WHEC, with our mission for women's health and education, stayed with me. And that is what kept me going. And then I'm just going to, so we've talked about the missing link is education. What works? Simple, scalable solutions, women-specific hygiene kits. So we talked about now moving forward, a lot of the organization that I met, we've talked about a long-term solution or being proactive in future. So women were educated to keep some of those medications, like there's Alka-Seltz syrup, like things that are readily available in the market. Uh, Women should just keep those at home, and health workers and volunteers are needed. Um, Sanitation spaces, uh, clear messages on education and health, and I would say small interventions save lives. And education is the life-saving tool. And Dr. Rita, if you don't mind, can I also ask you to take over and say something? In the meantime, I will pull in the link. Like you've heard all this, and you know that, and I have read your work on UTI infections and women's issues. If you can please speak for 2 minutes, I want to. I'm going to pull some pictures so I can show you a bit of my work.
Okay, yes, we are running out of time, so hurry up. Yes,
Sure.
Lucky, you're doing a fantastic job, and I know UTI and the kidney failure is very high in these bad situations. Um, I am glad, but indiscriminately using antibiotics, here we go to Manisha's subject, is not the right idea. We need some healthcare people on ground and the basic lab facilities on the ground just to make sure you
Hmm.
are treating the right people with the right antibiotics at the right time.
Yes.
Uh, Otherwise, the circle goes on. Uh, you got your slides
Yes,
or
another slides. I got some of the
oh,
pictures. Of, they're
okay,
just
give
they're just here.
yeah,
I'm just bringing them up. So give me 1 second. Oh,
okay, go ahead.
can you guys see my screen still?
Yes,
Can you
yes,
see the WhatsApp screen?
yeah,
Okay, sorry. Okay, this is the only way I could find to do it. So
okay, here we go. Yeah, I
okay,
can see the
so
pictures,
yeah, so here this is the
flood
very first.
water and everything. Yes,
Yeah, this is the first one that we went to. So this was the first camp. And another thing that we noticed was that young girl as young as 8 were having periods. So I took my time, and we talked to the young girls, and this is when we found those 35 women, when we talked to them.
yeah,
And this was our work in the evening. The girl, a lady that's sitting right next to me, she's the one that cried a lot. She's the one
yeah,
that shut the door on me, and she's the one became my biggest advocate there. And the lady next to her gave a very strong message to us because her daughter was 21-year-old, but she was mute and she needed help. She needed the medication that day because she had a lot of pain. And then we were able to, assist with her. And the young girl on the right side is Prabjot. She's an amazing advocate on women's health. She's a nurse by profession, and I am so proud. And I was like lucky that I met her there. And this is and this is another team that I worked with. So again, when I talked about me, so these are the clothes that I wore. I was relatable. This is another village. This is where I want to share a story. We got a gynecologist in this village. She stayed with us 1 hour, and she told us, she's like, they're just villagers. I'm saying the literal words, and it was so sad to hear those coming out of a female doctor who we thought was there to help us. And she said, they're not never gonna understand. Just leave it and go. You know, that was very sad. And this was my way. This is what I advocated, that we have to tell them how they want to hear. If they want to, some of them covered their faces, some of them didn't want to be on the camera. And what we were noticing, big thing was, one of my colleague talked about it, is influencers. They ruin everything. We had people are going there just for videos. and they're exploiting these people. And that is what why our the lady Gurjeet, she yelled at me. She said, "Do not bring the cameras." And see, if you notice, a lot of these women shared a lot other issues. This wasn't just one. And so this is some of my work. I'm going to go very quickly. So this is the flood water. Like, this is what we drove through. This was up to my car window. Look at this.
Yeah.
So this was, and this is another one. This I always find, like, I love this picture. And then, yeah, this is us. So yeah, that was my work. And then I have a lot of videos on, so these are some of these girls are now our advocates there. And this we just continued the work just continued for one full month from one
Yeah.
village to another. And the big one was this one. This is the one. There is a huge river, Ravi, which comes all the way at the end. And after that, there are 7 stranded villages. This was reaching to this woman was a challenge. We had to take this. So there is a bridge that army makes every year only for a few months, and it gets taken away after the when the monsoon hits. So these villages always get cut off, and they're right on the border of Pakistan. So this is the boat that government has given us, which you can't even use. So people kind of came up with another motorized boat, and that is what we used. And we went and we were able to give this lady the medicine, as well as reach out to the other 7 villages. And now the goal is to go back to those villages, because they get hit by flood pretty much every year, so that making sure that they have right tools in places. I did partner with a lot of other organizations like Global Sikh. Khalsaid, I had a very, Ravi Singh had called me right after, I think, this visit. And obviously, goal is to work together with many more organizations. And I believe that the collaboration is the key. So this
I
is
am
just
glad. Lucky, I have to stop you because
no,
we
no, no,
ran out of the
no.
time.
No,
Sorry
no
about it.
problem. So yeah, this is basically us, our work, and I will
Excellent work.
continue this work. And sorry, these are the videos you guys can see on Global Grow Power's page. But yeah, that is some of my work, and I think my major message is, I'm just gonna maybe see you guys, your faces here. I'm gonna stop the sharing.
Well, thank you. Excellent work, and continue. Now,
Yes.
before we are really running out of time, but Dr. Donna Jenny, NGO representative of WHEC at UN New York, and she is with the Tools for Teachers, is presenting NGO statement, Unlocking Potential Through Higher Education. Go ahead, Donna.
Good morning, everyone from snowy Massachusetts. I am Dr. Donna Jenny, and I'm honored to present the UN NGO statement for this ECOSOC Partnership Forum event. The Women's Health Education Center has launched a successful new initiative titled Learning Life Lessons to support teachers, students, parents, and community in facilitating the goal of quality education. Quality education is the single most important investment that any country can make for its future and for its people. Community partnerships are essential as well. For example, in the city of Springfield, Massachusetts, at the Springfield Museums, was a recent multi-month community exhibition titled Witch Panic. This exhibit featured an accurate educational perspective on the history and persecution of a woman and a man falsely accused of witchcraft in the city of Springfield, which actually predates the infamous Salem witch trials. The exhibit culminated in an event held inside the stunning George Walter Vincent Smith Art Museum titled Bewitched. This was an enchanted evening featuring culinary concoctions, live music, and magic, where every step down the witch's path was a delightful reminder that art connects us, education invites us to ponder, and community uplifts us on our path to learning more about being a good citizen. Why does this matter? The educational highlights of Witch Panic go beyond the obvious details. The exhibit in its celebratory finale invited the community to reflect on how uncertainty and fear can shape entire communities. Understand how ordinary human experiences can be instantly transformed into extraordinary judgments. Appreciate the power of context in interpreting history, myth, as well as the evolution of witchcraft. In summation, the exhibit turned an historical moment into a mirror for our own times. It reminds us that education, curiosity, and critical thinking skills, as illustrated in WHEC's life lessons, are our very best tools for overcoming fear and the quick judgments fear alone leads to. Such an event fosters education along with enjoyment while bringing the community together. Springfield's mayor states, one of our greatest strengths is the diversity of our city. Bay Path University's 2025 Women's Leadership Conference was attended by more than 1,500 attendees, empowering women in business, leadership, and community roles. The 28th annual conference brought together educators, professionals, and community leaders for a full day of inspirational professional development. The theme was Amplify, focusing on stepping into one's power, elevating voices, and driving impact in professional and personal areas. Hoda Cobb, award-winning journalist and longtime Today Show co-host, delivered an inspiring keynote on amplifying voice and developing leadership presence, underscoring resilience, honoring oneself, and community purpose. During the breakout sessions, Jackie Glenn held a workshop, Courageous Conversations, educating the audience in strategies fostering inclusive dialogue for the purpose of ensuring that every voice at the table is heard. The WLC created opportunities for networking, and attendees were connected with exhibitors, providing a wealth of service and policies that support women's professional lives and community engagement. The Women's Health Education Center's series of learning life lessons illustrates that education, community, and lifelong learning go hand in hand. We welcome everyone and encourage everyone to read our monthly newsletter. Thank you so much for being with us.
Thank you, Donna. And to the audience, if you have any question for any of the speakers, please contact them directly. We ran out of time, so thank you very much. I have